So our next speaker is Scott Jensen. Scott is a master-level clinical social worker and a member of the Motivational Interviewing network of trainers. He has been working in the field of problematic substance and process abuse for over 25 years and has practiced in his home province of Alberta, the Yukon Territory, and since 1998 he's been with the Nova Scotia Health Authority in addiction and mental health program. For the past 10 years, his focus has shifted from providing direct clinical services as a clinical therapist to a clinical practice educator, providing staff training, coaching, and development with an emphasis on motivational interviewing. I don't think he's got that dog by the name of Rip motivated to do anything yet. Scott completed his training at St. Francis Xavier University in 2006, and he's with the Nova Scotia Health Authority in private practice, and he has the pleasure to train professionals from numerous healthcare fields: mental health, public health, recreational therapy, social work, and nursing. He also provides training to allied professions such as corrections, homeless shelter staff, and community service personnel. He enjoys frequent opportunities to teach motivational interviewing to graduate students from the faculties of social work, physiotherapy, and therapeutic recreation. He resides in Dartmouth with his lovely wife Joanne and their extremely unmotivated greyhound named Rip. Welcome, Scott.
Well, good morning, everyone. Part of my master plan is to have such a long bio that it takes up half the speaking time. So that worked out well. Just a show of hands, how many people have taken any kind of motivational interviewing training? No one. So I can pretty much just make stuff up now, can't I? This is going to work out better than I thought. The title of this presentation is Giving People a Darn Good Listening To. I think people are familiar with that story of Johnny in elementary school being sent to the principal for a darn good talking to. This turns this on its head. Part of our job as healthcare providers is being the one person in that person's life to actually take the time to hear them. Has that been anybody's experience when you worked with a client or a patient and you know on some level that they don't have a whole lot of people in their lives who actually pay attention to them other than a very negative setting? Okay. I like Plato. Plato stated the greater part of instruction is being reminded of things we already know. That's the nice thing about my job. Nobody's going to fall off their chair about any kind of new ideas. But it's amazing what I know in a nice, calm, relaxed setting such as this, and how much I can forget when I'm in a situation where I'm frustrated with a client or a patient. Has that been anybody's experience here besides myself? There'll be a number of dumb questions. That's just the first one. So whenever I do one of these talks, I like to start just with a couple of questions for you guys. How many people here, just a show of hands, how many people here really enjoy being told what to do? I'm not talking about when you're actively seeking guidance or kind of instructions. I'm talking about that good old-fashioned, unsolicited, you know what you need to do? Diane, what you got to do is, Dr. Davis, here's what you need to do. Apparently there's something behind that because I just got to laugh. We might be onto something here. Question number 2, how many people, again, just a show of hands, really enjoy being told you're wrong? Dr. Davis, anything you want to add? And again, I'm not talking about when you actively seek out feedback and direction. I'm talking about that good old-fashioned unsolicited. Now, how many of us in healthcare, I'll speak in the I, how often do you think I inadvertently do that to the clients I work with? Who said never? God bless. Okay, it happens all the time. Inadvertently, and I have good intentions. I do believe we are on the side of angels. I have no doubt about that. And I think a lot of times I will inadvertently fall into that trap because I want the best for my clients, and it's my default setting. Simply tell them what to do because what they're currently doing is wrong. What do you think happens? Nice and loud. Back there?
Defensiveness.
Okay, defensiveness. Anybody experienced that one yet? Has anybody here been on the receiving end of a yeah, but? Anybody here have kids? Anybody here married to me? And I think people understand there's very little yes in a yeah, but. Yeah, but actually means no, because. So when I'm getting a yeah, but back from somebody, it's vital feedback if I take it as feedback. All they're telling me is, this is not appropriate because. What do you think one of the things I fall into when I get a yeah, but? Has anybody here ever given a yeah, but back to their patient? Yeah, never. Okay, just me. I've done that. I've given yeah, buts back to my patients or my clients. Motivational interviewing is about developing a conversational style of therapy that helps people evoke for themselves their reasons and ability to work through ambivalence and actually make change. Because if I try to do the work for them before they're ready to do so, the response I get is defensiveness and yeah, buts. That's easy to remember in a nice, calm, relaxed setting such as this. It's quite another when somebody's in front of me and giving me a lot of pushback. So I'd like to start with some guiding principles as we do this talk. The first one is healthy behaviors are abnormal behaviors. The reason I say that, are people familiar with the pleasure-seeking principle? If it feels good, do it? Of course. It's alive and well in all of us, not just our patients and clients, but in all of us. It's there for a reason. It stops me from touching a hot stove more than once. It also gets in the way of embracing a lot of healthy behaviors, because healthy behaviors are based on delayed gratification. Short-term discomfort followed by long-term benefits. I'm going to give you guys a couple scenarios here, and you let me know which one applies to me. Option number one, when I come home from work, I immediately go upstairs, put on my gym clothes, go down to our basement, and jump on our treadmill for a nice 30-minute run, followed by a nice healthy bowl of raw broccoli. You see, I haven't even given you the second option yet, and you guys are already laughing. As healthcare providers, that's kind of mean. I'm just putting it out there. Second option, I come home from work, I throw my jacket on the banister, I go to the cupboard, I grab a bag of Doritos, I sit down on the couch and I watch The Big Bang Theory. Well, thanks for coming in, everybody. Drive careful. Yes, the second one is more likely. Is it because I don't know the benefits of healthy lifestyle? How many people here, understanding that in a nice, calm, relaxed setting like we have now, fall into that pattern of trying to convince somebody to make healthy behavioral changes by educating them into change? If you did this, you would be able to do this. Education's important. Information is important, provided at the right time. If I'm working with somebody who's ambivalent about change, and I try to educate them into change, what do you think the response is? Yeah, but, which means no, because. So, healthy behaviors are abnormal. I keep that in mind coming right out of the gate. When I'm working with somebody, I'm behind the 8 ball. It's just the reality of working in healthcare. There are easier ways to make a living. I don't know what you people were thinking, but there's easier ways to make a living. We are behind the 8 ball. We are actually working against people's very nature. And it's no surprise why we get pushback. But if I keep this little piece of information tucked in my head, it helps me remain focused and calm when I get that pushback. The second principle, people are influenced more by the sound of their own voice than by others. This is important. If I get into a debate with a client, and I'm trying to convince them to make healthy changes, and I'm getting the yeah buts in return, all I've done inadvertently is allow that person to hear themselves say out loud the reasons why change isn't important. And whose voice has the greatest impact at the end of that session, whether it's 2 minutes or an hour? Theirs. So my job isn't to convince people. My job is to set up a conversation in such a way that the person can evoke their own reasons for change. Because if they hear themselves say it rather than me, that has a much greater impact. Third, behavior is driven not by health outcomes, but by social and psychological factors. Going back to my 2 scenarios, it's not that I don't know that exercise is important. It's not that I don't know that healthy food is important. What trumps a lot of my behaviors is the emotional drivers. So oftentimes where I fall into trouble is when I try to put a logical template in working with people to make healthy behavioral changes. I try to convince them. I need to get to the emotional kind of drives in the first place. People don't act in random patterns. People do things, even unhealthy things, for very legitimate reasons. Simply trying to convince somebody to do it based on logic, when there's a stronger emotional drive not to do it, I'm going to get frustrated. People are more interested in their own reasons for change than ours. That ties into what we talked about just a minute ago. If I try to convince somebody with my reasons why they should change, I'm going to get the yeah buts, and they're going to give me their reasons for not changing. And people are much more interested in their own reasons for doing anything than my own. So again, my job is to set up the conversation in such a way that the person is allowed to state their reasons and benefits for change. Even if they're not going to do it for a while, if people are influenced more by the sound of their own voice than mine, I want to set up the conversation in such a way that they provide their own reasons for change. That takes a tremendous amount of pressure off us. Finally, our task is to help people to become willing to do what is healthy. I used to say it's our job to get people to want to do what is healthy. I think that's overstating it, and I think that's aiming for the stars. I think a lot of times, if I can help somebody become willing to do what's healthy, that's success. So if somebody is working with me and trying to change my lifestyle behaviors, that when I come home I actually go for a workout, chances are I'm never going to be at that part where I really want to go for a run on the treadmill. I'm willing to do it because of the outcome attached to it, but I don't want to do it. And yet in the course of our conversations working with clients and patients, how often do we use the word want rather than willing? Just keep that in mind as you work with people in the future. If we can get them to be willing, that in alone is success. So, as healthcare providers, shout out your answer. Smoking, good or bad? Yeah, we say bad, and we'd be absolutely wrong. Because my question wasn't, is smoking healthy or unhealthy? My question was, is smoking good or bad?
Depends.
Okay, Switzerland, who said depend? Okay, go ahead.
Well, if you're an isolated person, you work in a little basement, and the only contact you have in the day is when you go out and the other smoke buddies are out there in the blizzard, that's your social interaction for the day. If you quit smoking, now you're in your little corner and you don't see anybody. That's bad.
Absolutely. I don't know if anybody's ever worked in a smoking cessation program before, but if you ask that question to the clients, is smoking good or bad, often you're going to get, are you kidding? It's awesome. I miss it so much. So just very quickly, what are 3 legitimate reasons, and again, I'm not promoting smoking, but from the client's perspective, what are 3 legitimate reasons or 4 legitimate reasons for smoking? 1 is a social thing. Anxiety, it relieves my stress. Okay? Okay, up front here, nice and loud. So it's a weight control mechanism, stops it from eating. Somebody in the back, nice and loud. It tasted good? Okay. There's one that people often forget. It's an addiction. Oh yeah, that one. When nicotine levels drop too much, people get uncomfortable. So it's a way to avoid discomfort. So to your point, people don't act in random patterns. We do things for a reason, including self-harming behaviors, such as smoking. And that social thing is so interesting. And I do believe even today in 2016, employers are much more willing to let somebody to go for a smoke break, as opposed to if I said to them, I want to take 10 minutes and practice mindfulness. I want to take a 10-minute break and do some yoga. I want to take 10 minutes and go for a walk. Even in today's society, I think there's, no, you do that stuff on your own time. You're here to work. Now, why don't you go have a cigarette and think about what you said? So it's very much a cultural thing as well. My point is, as healthcare providers, or I'll speak in the I have a built-in bias. I equate healthy with good, unhealthy with bad, which is just the opposite, again, to your point, for a lot of the people that we work with. The same behaviors that I see as problematic, they see as the solution. Now, smoking is a classic example, but we can take it on the realm of other issues as well. How about depression? Somebody with a severe depression spends an inordinate amount of time in bed. As a clinician, I would look at that as bad. I want them out of bed. From the patient's point of view is, yeah, I might not enjoy it, but it's better than. It is the solution. Somebody with a lot of anxiety who has a hard time getting out of the house. Well, I'm all for that behavior activation. Let's get you out of the house and get you living again. No, leaving the house is bad. Staying in where it's safe is good. So right out of the gate, we're working from two different perspectives. My first task is to understand the emotional drives behind any behavior. What I might perceive as bad, they perceive as good, the solution. I don't want to stop there, but I want to demonstrate that I get it. Empathy is so important. Dr. Harris talked about that in the first session today when he talks about working with a difficult patient. It's hard to argue with somebody who agrees with you. So those empathetic statements back go a long way. Smoking, that's a tough one to give up. I mean, that's your basic catalyst for your social life. If you did decide someday to do something about your smoking, how do you think your life would be different? So instead of telling them, I'm asking them, and they have the opportunity to hear their own voice articulate why life would be better if. Is this making sense so far? Because I'm just making it up. Sometimes change is welcomed. I keep waiting for the big aw. Well, if I have to give that line, it doesn't count. Sometimes change is welcomed. Oh, it's going to be that kind of morning. Okay. Sometimes change is welcomed. Sometimes it is not. Oh, yeah, that gets the big aw. So, disclosure. I've been using this slide for quite a while. I think about 6 or 7 years. I was doing a talk at Dalhousie in the Tupper building for about 70 fourth-year nursing students. I showed this, and the place went quiet. You could have heard a pin drop. I don't know what happened, but I had 70 nursing students thinking that was actually my cat. I got this off the internet. So sometimes change is welcome, sometimes it isn't. What are the factors that determine how people view change? Now, just a show of hands, a quick look at change. Shout it out when you think. And again, where you lean more. I don't need any Switzerlands, yes and no. For the most part, is it true or untrue? Let's start with the first one. People dislike change. True? Anybody want to say false? Oh, I bet you're a kicker at work, aren't you?
It makes a diplomatic society.
It does. Actually, I agree with you. I think that's more false than true. In the courses of your conversations during the day, how often do you talk about change? If only I'd win the lottery. If only I had a different boss. Just an example. If only I had a different patient.
Change is good.
But they don't want to change themselves. They want to change the environment.
I'll say that again, nice and loud.
I said that's a change in your environment. They don't do anything with that. They want to change themselves.
Right, I think, and that's the key difference. It's not that people dislike change, and remember, I kept this very short, just change in general. It's not that people dislike change. We talk about change so much. I think what people dislike is feeling like they're being changed. And there's a difference. But we often kind of overemphasize, well, that's just because people dislike change. No, there's actually something else going on here. People give us feedback and information all the time. Motivational interviewing is a style or a method of therapy where I pay particular attention to that feedback. And so when I'm getting pushback to change, it's too easy for me to say, well, that's normal, people dislike change. No, people actually don't dislike change. What's happening in this encounter? Why are they putting up some pushback or some resistance? So yeah, to your point. How about this one? Repetitive patterns of self-harming behavior are normal. And I'm not talking about the far end of the continuum, the cutting kind of stuff. I'm talking about that general stuff in society. True or false? Oh, you guys were so sure of the first one.
Okay, true.
No, I think that's true. I think that's true. And we talked about that already. Healthy behaviors are abnormal behaviors. I think it's totally, totally normal to have repetitive, harmful behaviors. As healthcare professionals, what are 3 or 4 of the major health concerns a developed nation like Canada or the US are facing today? Obesity. Diabetes. Mental health. Addictions. So of those 4, how many of them are directly influenced by lifestyle behaviors? Yeah. This is why I like doing these talks, because lifestyle behaviors affect everything we do. And yet, we work in a healthcare system where we're very reactionary. I mean, we've got a great healthcare system, don't get me wrong. I'm proud to work in it. I think at the same time, we are quite reactionary. We wait till there's something problematic, and we try to solve that problem without taking a good enough look at what are the behaviors contributing to it. Or if we recognize it, we fall into that acute care model, which is a great model of medicine. Acute care, I observe, I diagnose, I treat. That works great for acute care issues. If I end up in an emergency room with a broken leg, I'm not that concerned if my surgeon is well-versed in motivational interviewing. I don't need somebody to help me work through my ambivalence about having a broken leg. So Scott, what are some good things and not so good things about having a broken leg? I don't care. Fix it. Following the surgery, where my job starts to kick in, because I have a part to play in my recovery, that's when it's more lifestyle behaviors. Scott, what are some of the good things about attending your physiotherapy? How would your life be better if you chose to do that? Which is different than you need to go to physiotherapy. How many people here really enjoy being told what to do? And again, it's not that we're not on the side of angels. We are, and we make perfect sense, and we're perfectly correct. If you want to get better, you have to go to physiotherapy. The kicker is, it's never the message delivered that's important, it's the message received. And people have a funny way of defending their autonomy even to their own detriment. People will defend their autonomy even to their own detriment. Nobody tells me what to do. Has anybody experienced that? Has anybody ever got frustrated because you're having the same conversations with the same people for the same thing, and you know, both ethically, scientifically, common sense, that what you're saying is right? If they'd only do what I'm asking them to do, their lives would be improved. And yet, for some reason, yeah, but. I really believe, and one of the things that they don't talk a lot about in motivational interviewing, but I think is a key, isn't just about influencing healthy behavior change, but for our own health care, working in health care. I think there's a lot of burnout, and yes, extreme workloads, lack of resources play a part in it, but I think a lot of it has to do with just the ongoing frustrations of people not allowing me to help them. Again, has anybody ever experienced that? By the way, that was stupid question number 2. Everybody should be nodding their heads at that one. How about this one? If people can be made to feel guilty or fearful enough, resistance will break down and they will in fact change. Okay, just show of hands, mostly who think that leans towards false. Okay. Actually, that's true. It works like a charm. What it doesn't do a good job is sustaining the change. This used to be the catalyst for addiction services. I mean, until the early 80s, it wasn't uncommon to have what we called the encounter groups or the hot seating. Basically, it was based on the premise that our particular clients had an overdeveloped sense of that psychological defense mechanism called the river in Egypt, denial. And in order to get through that denial, we had to break them down for their own good. We had to shame them into change. Because that denial meant they had an elevated sense of resistance. What we found since over the last 3 decades was if you pulled anybody off the street and you treat them the same way we treated our clients back in the day, they reacted the same way. Defensive. How many people here enjoy being told what to do? Nobody, including clients. So the more they resisted, the more I piled on. When I say I'm talking about the profession itself. Because we could say anecdotally, well, it works. People make changes. But they're short-lived. The motivation wasn't to change. The motivation was to get guys like me off their back. And there's a difference. And that applies to healthcare for all of us. Please don't confuse motivation to avoid an outcome with true motivation wanting to make changes. So a big part of my professional background is working in problematic substance and process abuse. Do you think we ever had people coming to our services not because they wanted to make changes, but because they wanted to avoid a consequence? Of course. 80%. A lot of times people came in very pre-contemplative about change. I don't necessarily want to do anything about my alcohol use, but I don't want to lose my family. I don't want to go to jail. I don't want to lose my job. That often comes up. And it's easy for me to confuse those two and just be totally stunned when they relapse. Well, they relapse because there's really no motivation to change. There's motivation to avoid a consequence or a crisis. And if the only thing that motivation is tied to is a crisis, what happens when the crisis dissipates? So does the motivation. Behaviors are emotionally driven more than logically driven. What happens to gym memberships come January 2nd? Is that because somehow on January 1st people become more aware of the benefits of exercise? What's driving people's tendency to massively increase their gym memberships? Guilt. Guilt is a powerful motivator. Guilt is also a short-term motivator. What happens with the same gym memberships come mid-March? They go down. Because what's driving the behavior is simply guilt. Guilt dissipates, so does the motivation. How about this last one? Resistance is often a common personality trait which people bring into and maintain in client-helper relationships. People always get so quiet by the time we get to question 4. How many people say true? How many people say false? How many people are just not going to take a chance at this stage of the game? Right here. Actually, that's false, because resistance isn't a personality trait. I'm not saying personality doesn't play a role in it, but resistance is an observable behavior. And that's interesting. And what we know from 3 decades of research around motivational interviewing, we can actually turn up somebody's resistance to change, or we can decrease it simply by how I encounter them. And we've done this through cycles of a 9-minute test. For 9 minutes, we take more of a confrontational approach, and people start getting resistant and pushing back. At the end of that 9 minutes, we go for 9 minutes of more of a motivational interviewing approach, resistance drops. And we can do that, and they demonstrated that. Resistance isn't so much a personality trait as it is as a byproduct between 2 or more people. So when I'm getting pushback in a counseling session, I can't simply say, well, that's their personality. I have to start looking at, what am I bringing to the party? What am I doing to actually increase their levels of resistance? And it comes down to those 2 questions. How many people like being told what to do, and how many people like being told they're wrong? How easy is it for me to inadvertently give those messages, even though I'm on the side of angels and I want them to change? People protect their autonomy to their own detriment all the time. Some very quick definitions of MI. I'm not going to read it, but I just want to point out in the second part of that second definition, it talks about the language of change. Motivational interviewing isn't based solely on motivational psychology. It has a lot to do with linguistics. So when I'm working with people and training them in motivational interviewing, a lot of it has to do about helping them actually develop almost like a new language. They have to listen for those language of change and capitalize on it. And it's amazing how hard that is to do. So when I do a training, like a typical introductory training, we start with a 2-day workshop followed by about 6 months of individual coaching and group supervision, at which time the clinicians actually have to submit audio recordings of their work for review. We have, 40 minutes today? I might have to gloss over some stuff. But the definition I like the most is by Stephen Rolnick, who is one of the originators of MI. It's simply a gentle conversation about change. If it's not gentle, if it sounds like a debate, if it feels like a wrestling match, it's not really MI. Has anybody ever come out of a clinical encounter just exhausted? Number 3, by the way. Has anyone here ever felt like you were more motivated for the person to change than they were? Whose job is it to articulate the reasons for change? The patient's, right? My job is to set up a conversation in such a way that we guide them into making those kind of statements. So they are actually guided into making change talk statements, and then I capitalize on that. And that's not manipulation. Manipulation is when I get people to do something against their will. This is a guiding conversation. I'm not putting words in their mouth. I'm simply asking them questions in such a way where they answer them. We talked about that first point already. The second point we spent a lot of time on in training is called the Righting Reflex. As a clinician, and if I observe somebody doing something that I perceive as bad, because I have that bias, my job or my first inclination is to try to fix it, to make it right. So if you're smoking, what do you think my first inclination is? Right, I want to tell them to stop. And again, people really appreciate being told what to do. And then I'd follow that up with, not only do they have to stop, but here's the reasons why. Because people just love being told they're wrong, too. So a patient goes to their family physician for respiratory problems. The physician finds out that the person is a smoker. Typically, the physician will address that. How it's addressed will determine if the patient hears it or rejects it. Any Dr. Phil fans here? Dr. Phil has kind of 2 taglines. The first one is, how's that working for you? But the second one is, what you gotta do is, and I'm from Alberta, so the Texas accent isn't that big a stretch. What you gotta do is, and again, what he's talking about is probably very scientifically valid, certainly common sense valid, but that doesn't mean anything because people don't like being told what to do, even if it's to their detriment. People protect their autonomy. So how do I get the message across without it being rejected? And that is the heart of motivational interviewing. It's a method of communication that allows the person to actually make the argument for change. How about this one? How many people are familiar with the theory of psychological reactance? Why would you? I just made it up. No, it's a real term. The way I remember it for myself, I just think about the Raggedy Ann doll theory. Think about parents of a young child. They're cleaning out the kid's room. They come across, in the back of the closet, a Raggedy Ann doll. And they say to that little boy or girl, why don't we give this doll to the Salvation Army? Now, this kid hasn't seen that doll for a year, hasn't thought about it for a year. And as soon as the parents say, why don't we give this doll to the Salvation Army so another little boy or girl can enjoy it? How does that kid react? I love the drama. A lot of times people just go, no, but no, there's a no. I like that. Yeah, it's amazing. In that moment, the value of that doll has increased. Think to your patients and your clients. If you want to make something tempting to somebody, tell them they can't do it anymore. We laugh, but how often do we do that? Maybe inadvertently, and maybe from the side of angels. But it's never the message given, it's the message received. You know what? We've only known each other for less than a half a day, but I like you people. I don't want anybody here ever eating coconut cream pie again. It's just not good for you. You better get some coconut cream pie, because now there's a lot of cravings for it. So that happens individually. It also happens from a societal point. What happened in the 1920s? That's a great example of psychological reactance in the United States. Prohibition. Law came down where alcohol was illegal. What happened? Speakeasy, bootlegging, people who never drank started drinking. Again, we laugh at this. But if you want to make something tempting to somebody, attach their freedom to it. You know what? You can never drink again. If you do, you're going to die. Yeah, but people don't like being told what to do. How am I doing for time? 35? So we're not going to get through the whole thing, and that often happens. But I do want to talk about motivation. I mean, this is motivational interviewing. We need to talk a little bit about motivation. There are 3 elements to motivation, and this is one of those situations where 2 out of 3 is not enough. For someone to be motivated and to act on that motivation, 3 elements are needed. A good way to remember it is ready, willing, and able. Whatever that change is, it has to be seen as a priority. In the midst of all the important things in my life, that has to be seen as up there. It has to be seen as important. Now, priority and importance often get lumped together. There's a slight difference, but just for the sake of understanding, importance and priority have to be high. But there also has to be a sense of confidence, self-efficacy attached to it, that there's actually something I can do about it. So, do you think there's ever a time when you're working with people and you scratch your head because I don't understand why they just don't make these changes? They know full well how their lives will be better with it, and they know full well why their lives are worse with it. And I try to increase their awareness by giving them some more education. I try to increase the priority and the importance. But what's often happening is, again, people are not dumb. People know. Family is still a priority and still important. But I've tried so many times to quit, and there's nothing I can do. Does anybody here ever work with adolescents? Anybody here have kids? Again, anybody married to me? So have you ever been on the receiving end of, I don't care? I don't care is often code for, I do care, I get why this is important, but I don't think there's anything I can do about it. But rather than admit that I'm powerless or I'm weak for the situation, I'd rather just wrap it up as, it's not a big deal. So understanding, again, the linguistics, oftentimes those statements of, I don't care, are code. I care very much, but there's nothing I can do about it. And it hurts less just to say I'm indifferent than I'm powerless. In the addiction field, I work with a lot of 40-year-old adolescents. And I don't mean that in a facetious way. The maturing process stops when the addiction takes over. If the maturing process is based on problem-solving skills, well, addiction is based on avoidance. So a lot of times I'm working with adolescent, 40-year-old individuals. And they're not dumb. They just don't think there's anything I can do about it because I tried so many times. So understanding those elements of motivation and listening to the language and the feedback they give is key. We must be just about out of time, right? Okay. That might be a good place to leave it. We didn't even get to the linguistics part of it, but like I said, it usually takes 6 months. I'm surprised we got through this much in 40 minutes. Are there any questions or comments before we wrap up?
What's a better alternative to what you should have done next?
What's a better alternative to what you should do? Okay, rather than, well, I'm going to put this out to the crowd. What is a better way of dealing with somebody who's resistant to change rather than just meeting it with more resistance? What you got to do is. Anybody have any guesses in the back? So you're describing, actually have them to be an active participant in their recovery and their treatment, what's been working for you, and filling this out, and what do you want to talk about today? So one of the things we didn't have a chance to talk about was the spirit of motivational interviewing, and the spirit is the philosophy behind it. And one of the things that we talk about is a sense of partnership. We both have a part to play in that person's healthy change, both attitudinal and behavioral. And part of that is, their part of the partnership is to identify what they want to work on. Now, I might have a good sense of what's actually more beneficial, but I can't change anybody. I wish I could. I'd be the richest social worker in the world. We can't change people. So we start where they're at, finding out what do you want to work on today? How would your life be different if you made these changes? And they talk about it, and they hear themselves talk about it. So to your question, rather than simply telling people what to do, ask them, what are the benefits if you did decide someday to make some changes? How would your life be better? So it's asking more questions and less telling. Now that's a very quick synopsis. There's actually more to it than that, but for lack of time. Yes?
Do you think that there is an epidemic now of youth being addicted to marijuana? And how is that going to change when they do make it legal? In your future, do you see that you're going to see more 40-year-olds that are going to have repercussions from this, or because of decreasing the chemical, supposedly the addictive chemical, or the psychotropic, what is it, HCT in it?
THC?
Yeah.
Yeah, so the question was, do you think we're going to be a spike in people developing addictive disorders towards marijuana now that it's become legal? I think the bigger question is, I think we live in a society where we're so ingrained for instant gratification. That's going to be a problem. So I was talking to my 86-year-old mother a little while ago, and we were just chatting about, I was telling her I'm doing laundry, and she talked about back in the day when she did laundry, that was like a full day event. Get the water in, heat the water, do that. Today, in 2016, we're so ingrained for instant gratification. If I can't find the remote for the TV, I have a meltdown. Because that is a crisis, people. I have to get up. I don't even know there's buttons on the TV. To your point, it's part and parcel of that finding yet another mechanism to avoid. Yeah, I have, and again, I'm just speaking for myself, not on behalf of the agency, but I have concerns about that too. I think of all the things we're facing in our nation and healthcare today, making it even easier makes it tough. Now, having said that, there's really no evidence saying that it spikes, because the people who develop problems typically would do it anyway, and it's like alcohol. But if you take a health promotion perspective, yes, availability does influence problematic use. How much? Who knows? This is going to be studied for a while. But I think it's just another thing to avoid developing problem-solving skills in society. So from that perspective, I'm worried. So I think we're out of time. I want to thank you for the kind invitation, and thank you for listening to me. Appreciate it.